Hello, everyone. Thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session. Norm, you have.
Thank you, Mara. It's good to be with you. We're excited to have you here again for our third Igniter session, part of our pre-conference events for the NATO 36th Annual Conference. This Igniter session is going to be presented by Julia Tremaroli from the Center for Improving Value in Healthcare out of Colorado. And the title and topic today will be Surprise Billing, the Colorado Lessons Learned related to out-of-network data. Before we get into that, just a couple of additional reminders that Marin alluded to. One is the game token challenge. We hope that everybody will do that, and especially now that we're getting close to conference time, that you'll go in and explore the platform, find those tokens, enter to win your chances, enter the drawing for your chances to win. It's going to be helpful for you to do that in advance. We also want to emphasize the importance of networking and connecting. So please use the wall to be social with other attendees. And within our session in particular, please use the chat to ask questions or even just make comments. It's very helpful for us to see your reactions to what's going on, especially to see those questions. Julia's bio is available. If you scroll down, you can see her bio on the same page that you're viewing that right now. And if you do navigate away, the Socio platform will keep you picture in picture so you don't lose the broadcast if you need to go check a bio or something else. So with that, I'm going to welcome Julia to the stage. Hey, Julia, how are you?
I'm doing great. Thanks. How are you?
Fantastic. Well, here we are, ready to go. Tell me a little bit about why and how you got interested in the topic of surprise billing. Why is that important to your state and to your organization?
Yeah, so Colorado back in 2019 passed a bill that addressed surprise billing, which in general, if folks aren't familiar with the concept, it's when a patient will receive a bill for something that they're not expecting. So the example that we talk about pretty often, although there's a lot of other examples that could illustrate this situation, is, you might do all of your homework. You might say, I'm getting this procedure done and I'm going to go to this in-network facility and my surgeon's going to be in-network and you're all ready to go. Then you have your procedure, and then a couple months later, you might receive a bill from the anesthesiologist who was out of network. And before the bill in Colorado, there was there wasn't any protection against that. So folks did not have the expectation to receive these bills, and they were financially responsible for it. So Colorado passed this bill there's quite a few elements that we can get into in a second, but and they named the Colorado APCD as the source of information for kind of repricing some of these claims. So I got involved in it because I started working on that project, and I've been involved in it for the last 3 years now. So
fantastic. So surprise billing, I assume it's a problem. I've heard about it on the news. How prevalent of a problem is medical debt or surprise billing? Is it? You have any data on that?
Yeah, there's a couple studies out there. There's one Kaiser Family Foundation study that says about 1 in 4 people, about 25% of people have had issues with bills like this. So it's definitely it's impacting quite a few folks across the population, and folks in Colorado are no different.
Yeah, well, let's talk a little bit more. I'm going to put up this graphic here. Let's talk a little bit more about Colorado's bill. You want to walk us through some of the provisions and what you're required to do and how it works in Colorado?
Yes, definitely. There's a lot of details in the bill, so we can just kind of jump in. So first off, in terms of the settings, the bill deals with services for out-of-network providers that are in-network facilities. So that means in that example that I provided before about the anesthesiologist, it might also be, just any other provider within when you go to an in-network work facility and there's the provider themselves, maybe the professional provider is out of network. It also deals with emergency care at out-of-network facilities. So the idea is if your arm fell off, you're not going to be trying to figure out the closest in-network facility and emergency room to go to. So you're not going to be stuck with some crazy bill. So those are kind of the two elements. So the professional bills, so the out-of-network providers in-network facilities, and then the out-of-network emergency facilities. And the other part of it is that it holds consumers harmless and only just they should only expect their normal in-network cost sharing. So it's not like it's going to be totally free to them all the time, but it'll at least be they'll be only subject to the in-network cost sharing that they would normally expect. It just applies to all providers, and it bans balance billing across the board. Providers shouldn't be sending out-of-network bills directly to the members. It should be going through the insurance company. And then this is where it gets really weedy and fun for us data nerds. The payment standard is for the out-of-network provider. So the legislature did a lot of different math, really to the very last, the 11th hour of passing the bill. So they landed on for the out-of-network providers part of it. So the professional bills, the fee structure is either the greater of 110% of the median in-network rate for the insurer, or the 60th percentile reimbursement rate of that same geographic region based on claims from the Colorado APCD. So that's, whichever one is greater, that's the reimbursement rate that we should go with. And then for emergency services, it's the same process and it's the same idea, but instead it's 105% of the carrier's median in-network rate versus the 50th percentile from the Colorado APCD. And if the parties, after they've gone through this whole process, if the parties still disagree on the payment rates, then there's an independent dispute resolution process through the Division of Insurance that they can go through.
Okay, so somebody has to calculate all these percentiles, I would assume. Is that where Civic comes in?
Yep, that's our big moment when we get to every year we produce fee schedules for all of this. And I think the next slide will show you an example of what that might look like, or what it does look like. So in the bill, it requires that there's a fee is produced by geographic region. So this first column just tells you which DOI region. There's 9 regions across the state. So this, in this screenshot, you can only see just a little sampling of some fees for region 1. And then it shows you the CPT code. In this example, I Googled it just now, and it's fine needle aspiration. So this very first one, 10022 with no modifier. This is the 60th percentile. So this is what we calculated from the Colorado APCD to be the rate of reimbursement for this portion. And then this last column you can see, and we can get into this in a minute, but if it's using the 60th percentile for that particular region, or if it's all across the state.
Okay, and then how often do you have to produce these schedules for the state?
It's just once a year. So we do it, it's for the following calendar year using the previous calendar year's data. So what we do is around November-ish time each year using the most up-to-date data. We produce those fee schedules for use starting in the next January.
And you've done this how many times now?
This year will be our 3rd time. So we have some experience under our belt. We're still learning quite a lot, but yeah, we've got a pretty good process down now.
All right. Well, let's talk about what you've learned. So what are some challenges that you've faced and overcome?
Many challenges. In the first couple years, especially that first year, it was just a lot of trying to figure out, what should this methodology be? And we discovered a fair amount of data quality issues just with the data that was submitted to us, specific to anesthesiology units. Well, first of all, we had to figure out the process or the methodology to actually price the claims for anesthesia. But then on top of that, figuring out if there's actual data that can come through that actually works. So, but then beyond that, we had some volume issues. I mean, there's hundreds and hundreds and thousands of CPT procedure codes. And sometimes there's just not enough volume for us to price things. So that was another issue that we had to encounter. I mean, we just landed on a 30 claim threshold. We had to have at least 30 claims in the region or across the state to be able to produce those fee schedules, to at least to produce a stable estimate for the fee schedule. There we go. So yeah, there was lots of different issues, I wouldn't say issues, but challenges that we had to overcome, especially in the first year, but we've learned quite a lot since then.
All right. So what are some of the challenges that you continue to face? Are there any things out there that have made life difficult that you have not yet conquered?
Yeah. So, well, actually, one other issue that I want to bring up, just in case any folks are listening and they are embarking on this journey themselves, which I forgot to mention, which is just the idea of units in general and what the methodology is to price those claims. The first time we produced these fee schedules, we just did a flat rate across the board for all of these. If we had enough volume, we just produced the flat rate. And then we discovered, actually through a question that came through from a neuromonitoring provider. They came back and they said, I'm kind of confused about this rate. And we looked into it and we realized that we didn't price their claims on a per unit basis, because neuromonitor claims come through, I think it's on a timed basis. So per 15-minute increments or per minute or something. So we just produced the flat rate based on the 60th percentile. And that provider interpreted that to be a per unit rate. So they looked at it and they said, wow, this is a lot of money we're about to receive. So we had to kind of go back and say, oh my goodness, we're so sorry. So we had to go back and just decide on which claims and which procedures should be priced at a per unit basis. And of course, we had some issues before in the past with carriers hard coding their units fields, sometimes to just one. Just based on the way that they had submitted the data. So we had to go back and work with the carriers to fix those units. So we've fixed that now for going forward. But in terms of current issues that we're trying to tackle, and it wouldn't, again, I'll call it a challenge instead of an issue, is COVID. COVID is certainly, we're all kind of trying to figure our things out, figure out our processes, methodologies behind how to deal with COVID. And that's one thing that we haven't fully solidified the methodology to price COVID testing or COVID treatment claims. And that the interaction between COVID treatment versus the bill and the out-of-network bill is kind of complex. So we've been trying to just parse through that just from a legislative perspective, then beyond that, just how to make sure that the methodology is appropriate. So we're working with a lot of carriers and with a lot of providers to make sure that we're doing this in the right way. So more to come on that, but that's one of the issues that we've been running into.
Okay, well, let's talk a little bit about ideas for other states. So I have heard rumors that other states are considering surprise billing legislation of their own, and they're going to need to get this data from somewhere. So what would be your advice to any state that's thinking of doing this in terms of connecting to the right data?
Yeah, so I would say dive in as soon as possible. Start having conversations with your legislators, if the APCD or whatever the source of information is, whatever the source of information is and whoever's in charge of it, if they can get in on those conversations as soon as possible, that'll just make the process smoother. In hindsight, we wish we would have engaged a little bit sooner in terms of having some say in the language of the bill, so we could make sure that, so it was more clear for us to determine the methodology. But then beyond that, I would say just making sure that you review your data and all the data that you have to make sure that the quality of the data is up to snuff before you embark on this journey of producing these fee schedules that might impact a lot of people's reimbursement rates. Another thing is anesthesia and ambulance billing can tend to be very complicated. So we kind of figured out the anesthesia thing. We produced some conversion factors, and there's this whole crazy calculation to produce that, and then for that to be then applied. But that's just one thing that if anesthesia is involved, just dig in, just hold on to your seats, because it's definitely certainly a journey. But then beyond that, ambulance billing, ambulance claims are part of the bill, but the APCD ended up not being the source of information for that. And I don't remember where it went for that end of things, just because it was so complicated and there were some political questions with that as well. So that's one thing I would say, just for the complex methodology, anesthesia and ambulance, just pay attention to that.
Yeah. So do you have any solutions for what to do when you have things where the volume isn't really big enough to give you a precise estimate? What are there ways of dealing with that?
Yeah. So what we did is, because the requirement in the bill was, the quote was in the same geographic area. So we defined that as DOI regions. So the Division of Insurance, like I said before, there's 9 different DOI regions. And within those regions, if the volume wasn't at least 30, so there was a whole process that we went to determine that 30 threshold. There wasn't enough volume for that region. We would just go to the statewide and see if there was enough volume at that point, which seemed to address quite a few issues. But then beyond that, I guess the good part of it is that if there's not at least 30 claims across the entire state, then there's probably not going to be too much of an issue going forward. So that's, I guess, one good thing about it, but that's certainly an issue that we had to kind of grapple with.
Yeah. Is there any thought about maybe pulling together more than 1 year of data? Does that help? That is problems?
Because of the way the bill is written, we weren't able to do anything about that. We had to just use only the prior year, just 1 year worth of data. But that is something that if other states are embarking upon this, and if they want to make sure that there's enough volume, I would say, include 3 years worth of data, or at least 2 years. And if you want to do some sort of CPI adjustment or something where you can adjust those numbers and adjust for inflation, that might work. But that's something to consider.
And then do you have a formal process to get feedback from particular payer types, like the ambulance companies or the anesthesiologists, like some of the usual suspects where it's really challenging? Did they give you the ability to set up a process to talk to them about all this?
We actually, a lot of this is done through the Division of Insurance. So fortunately, we are set up. So Civic is kind of this separate entity we're not a government agency, but we work very closely with the government agencies. So the DOI was implementing this. So they have their own stakeholder process that they go through. And a lot of times they'll either just forward us questions from carriers or just connect, or not, well, it could be carriers, could be members of the public, could be providers as well. So they'll connect us with them if there's a question about the methodology or about the fee schedule. And then we have a pretty solidified process internally just to be dealing with those questions and issues.
All right, well, let's just check. I haven't seen any questions at all from the audience. It seems like we had some audio issues or video issues for a couple of people. We got those resolved, but we've got about 20 seconds left. Is there anything else that you'd really like people to know?
No, other than just we really enjoy working on this, and if anybody is embarking on this journey or they already have and want to, put their heads together with us, we're always happy to coordinate with other states and other organizations who do this kind of stuff.
Okay, well, fabulous. So thank you, Julia, for your time. And just to let everybody know, we will be back here on September 23rd, 1 week from today, 2 p.m. Eastern. We will have a discussion with two people, one from Maine and one from Maryland, on state work on telehealth. So again, another kind of timely topic, something that everybody's talking about these days. And thank you all, and we will see you again in a week. Bye-bye.
Thanks, everybody. Bye.